All right, we are going to go ahead and get started with our webinar today. And before we do, I just want to go over a couple housekeeping items. To ask a question during the presentation, please use the chat feature, which is found on the right side of your screen. And this is just a reminder that this webinar is being recorded, and we'll provide a link to this presentation from our website. So I'm going to go ahead and turn it over to our speaker today, Lori Graham, and let her introduce herself and her topic.
Thank you so much, Chad. Like you said, my name is Lori Graham. I'm a clinical therapist at the Women's Mental Health Program. We are a clinical research program located on the 4th floor of the Psychiatric Research Institute at UAMS. We provide outpatient mental health treatment to women who are 16 years old or older. Most of the women that we see are pregnant, postpartum. We have several that we see who are struggling with infertility or trying to get pregnant. And to be accepted, the criteria is that they need to have a mental health diagnosis, obviously. So many of them are dealing with things such as anxiety, depression, PTSD, bipolar. We provide services at the clinic. Dr. Stowe, the psychiatrist that I work with, he also provides services at the University Women's Clinic, and something that we're very lucky to do is to provide services through telemedicine. And so the picture on the screen there is actually a kiosk. For those of you who may not be familiar with telemedicine, we use interactive compressed video to provide assessments and ongoing medication management to patients who are in rural areas who may not otherwise be able to receive treatment. We're lucky to work with the ANGELS program, and that's the antenatal or neonatal guideline education and learning system. They collaborate with the Arkansas Department of Health to provide consultations for maternal fetal medicine specialists, or in our case, psychiatry, to physicians who are providing prenatal and postnatal care in county health units across the state. So we're very lucky to be able to provide that service to women. Oh yeah, thanks. Another feature of our program is the inpatient women's unit that just opened up about a year ago, a little over a year ago at PRI. So if we assess and determine that a patient is in need of a higher level of care, or they need some type of acute medication management adjustment or detox, so we've got the women's unit on the 5th floor at PRI. We've had several women that need to go there after pregnancy or postpartum. They may be struggling with depression or even often or sometimes postpartum psychosis, and so they're able to go there and receive treatment. It's an acute psychiatric unit, so the length of stay tends to be pretty short. 2 to 5 days is kind of typical. There's extended visiting hours to accommodate women who are breastfeeding, and they're able to still do that while they're there and away from the family. And then they have group therapy that they also participate in. So it's really nice to have that treatment option available for our patients who need it. So I know we're talking today about family violence, but I wanted to start with just a definition of a general definition of domestic violence. And one of the ones that I have found that I use the most is this pattern of assaultive or coercive behavior between two people in a relationship that includes but is not limited to all of those things that we see there on the screen. The Centers for Disease Control defines a relationship or intimate partner as a current or former spouse. It could also be two people who were formerly in a dating relationship. So that's a fairly broad definition, and it's similar to Arkansas's definition, broad enough to include many types of familial relationships. I'm planning to talk today in the next half hour about the risk factors associated with family violence, and we're going to review the effects of violence on child development and also briefly explore the relationship between partner abuse and child maltreatment. So for family violence, we're talking about violent or threatening behavior by a person with the intent to coerce or control a family member or cause other family members to be fearful. Considering that 1 in 3 women in the U.S. have experienced some type of intimate partner violence, rape, stalking, it becomes easy to see how these numbers are so high. So 3.2 million American children are witnessing domestic violence in the home each year. Up to 50% of the homes where violence is reported, there are children present. And a statistic that I found shocking was that up to 2/3 of the residents in domestic violence shelters are children. So it's definitely something that is common, more common than maybe people realize, and something that needs to be addressed. Factors that increase the likelihood of violence in the home are typical of things that you might expect to see. Most of these stressors are well known to negatively affect the quality of life or outcomes for children. Poverty, unemployment, substance abuse or alcoholism from the parents. The mother's age correlates to the likelihood or the higher likelihood that there may be family violence occurring in the home. So it turns out that the younger the mother, the more likely she is to be in a hurtful relationship. There was a study in Canada that found women who lived with heavy drinkers were 5 times more likely to be assaulted by their partners than those living with non-drinkers. The children who grow up in these homes often learn early on to solve their problems with conflict. Many may even be encouraged to use violence to resolve their issues. I worked in school-based therapy for a while and always was shocked and saddened to see how often the children in elementary school, even first grade, second grade, were using aggression to solve their problems. So the single best predictor of children who are going to become either perpetrators or victims of violence is whether or not there was violence in the home that they grew up in. There tends to be so much emotional stress that brain development is affected. Cognitive and sensory growth can be impaired. For infants, what you may see is irritability, excessive or inconsolable crying. Of course, feeding and sleeping routines can be disturbed. I want to point out also that during infancy, the babies might be at an increased risk for physical injury if there's conflict between the parents. You hit preschool age, and these children can start to exhibit aggressive behaviors such as thumb sucking or enuresis or encopresis. They may exhibit extreme stranger anxiety or separation anxiety. You may also start to have night terrors that develop. They usually tend to be whiny or especially clingy to their moms or to their primary caregiver. School-age children have difficulty making friends often. The social skill development might be lagging, and growing up in a home where your parents are fighting, that can definitely have an effect on your self-esteem or your self-confidence. So these children at this age may be experiencing more guilt or shame about the abuse. They may be blaming themselves. They may start to have trouble in school. Their grades can be affected. At this age, they may start to disclose more to their teachers or friends what's happening in the home. Up until now, what we've seen is mostly what we call externalizing behaviors, things like fighting, bullying, lying, cheating. But as you enter into adolescence, you notice more of the internalizing behaviors, which is what you think of more of depression, isolation, withdrawal. The behavior problems might become more serious. They may be more protective or guarded about the family and may not be so likely to disclose or talk about what's happening at home. During this pre-adolescence phase, you may start to see children who are acting out, in particularly with the parent who's being victimized. They may see them as weak and just act out as they're kind of struggling to understand what's happening at home and why it's happening. Problematic behaviors become more extreme during adolescence. So children at this stage will start to have more problems between, you'll see parent-child conflict occurring more often. They may be more likely to take risks or engage in antisocial behavior. They tend to have a more fatalistic view of the future. As they progress through adolescence, you might start to see other kinds of risk-taking behavior like early sexual activity, substance abuse, truancy, things like that. And adolescent women are one of the vulnerable populations who are prone to dating violence. Other groups of women who may be more likely to be involved in this kind of relationship include immigrant women, women with disabilities, the elderly, and unfortunately pregnancy tends to escalate violence. Pregnancy and postpartum can be a particularly stressful time on the family, and we see higher rates of violence occurring during those times. In the past few decades, there's been more awareness about the co-occurrence between domestic violence and childhood maltreatment. Of the children who seek medical treatment for being abused or neglected, there's 40% of those children report that there's violence happening at home between the parents. Exposure to violence typically falls into three primary categories, either hearing or witnessing the event. As children get older, they start to intervene more. There's also even instances of children being used as a shield against the abusive action, which can be particularly traumatic, or experiencing the aftermath of a violent event. So the police come, was a parent injured, has DHS been involved, all kinds of things may come to pass after a violent incident has been reported. There was one study of it was up to 146 children who looked at adolescents that were living in abusive homes, and in those homes where there were sons, 100% of those teenage sons had attempted to protect or defend their mother from the attack. I think that speaks to the emotional aspect of what's happening to a child when they're witnessing one of their parents be abused. And of those 100% of children who intervened, 60% of them were injured in the process. Excuse me. Says here the number one predictor of child abuse is woman abuse. And one statistic that I found quite disturbing was how much more likely daughters in the home are at risk of being sexually abused. And then, of course, the risk of injury goes up as the adolescent tries to, or the child tries to defend or protect the parent. So when a child presents with emotional behavioral problems, I think it's something we should all be doing to be assessing for family violence. Of course, child welfare and mental health professionals who work with abused or neglected children, they understand the relationship between the two that we've been exploring today. It's an important topic. Children who are in these at-risk families are 10 times more likely to be placed into the foster care system. I think even though what child welfare advocates and direct service providers do are different, they're common ground that we can bridge the gap between the services that we're providing. Spreading awareness to decrease domestic violence and maltreatment. Obviously, the goal is, for most of us, is to ensure the safety of the child and protecting the adult victim. I think it's really important to be able to empower the parent who's being victimized to make her aware that you trust that she's capable of making her own decisions and that really we can provide those resources, but ultimately it's going to be her choice. And I think that goes a long way to helping her make that decision to leave if she understands that she is capable of doing what she needs to do to protect herself and her family or her children. I think it's important to remember that some children are incredibly resilient. They may not be exhibiting the problems that we've been talking about. There are some protective factors that will make a child less likely to be exhibiting the behaviors and the problems that we've gone over. Things like having a supportive, non-abusive parent, strong sibling relationships or strong peer relationships, intelligence, and high self-esteem are all some of the protective factors that may make a child less likely to be affected to this degree. I think it's also to remember that witnessing violence does not necessarily constitute maltreatment. This is something that comes up quite often in our clinic because we see pregnant women, and as we've discussed already, violence tends to escalate during pregnancy. We often get the disclosure that violence is occurring in the home, and so and if we know that there are children in the home, we have to make that decision whether or not to call the child abuse hotline. And if we have some time, we may be able to talk about that in greater detail at the end, because I know that's something that can be a hot topic. Our policy in the program is to report if we know that there's violence occurring in the home, and I think as we've seen today, the likelihood that if violence is occurring, child abuse is more likely to be occurring, helps make that decision a little more easy to make. So children need adults who are listening to them. They need to know that they're being believed and that they can be protected. Having a sense of normalcy, having a sense of routine, being offered supportive services that are going to keep them safe and meet their needs. I think also what we can be doing when we're working with children is educating them on what is appropriate and inappropriate behavior in the family. So allowing them to learn that domestic violence is not okay and is not the norm, and teaching them nonviolent methods to resolve their conflict is really important. And we need adults, and I think that's part of our mission, is to speak out and break the silence of domestic violence, because it is still something that is not talked about and is probably as open a forum as it could be. Part of an effective response is to, of course, inform the patient that you're working with what resources are available. Safety planning, as we all know, is probably something that one of the first things we do, but letting them know what else is out there in the community for them. So I hope that you keep our program in mind when you're working with children and their parents, particularly their mothers, who might benefit from the services that we provide. And I want to just take a minute to promote the group that I lead. I have a domestic violence support group for women, and it meets every Wednesday at PRI at 5:30, and it is a free group. We've had an amazing response so far from the women who attend, and we're always looking to grow the group. And I think that if you refer people to our group, you'll find that it's been the support and the warmth that they get, and the sense of they're not alone that they get from the other women has really been remarkable, because so many of these women who are in relationships that are harmful feel so isolated and feel that it's something that is happening to them, and it doesn't happen to other people, and there's that sense of shame. And so coming to this group and meeting other women who are also or have been in relationships like that really does a lot to improve how likely they are to get out of that kind of relationship. And then I've got practical resources available to them as well, things that I can provide, that we provide, how to get an order of protection, domestic violence shelters that are in their area, things like that. So it's been very helpful. So we have a few minutes left if anybody has questions. I know this has been a brief presentation today and probably breezed through a lot of that, but if you have questions, my contact information is on that last slide, so I'd love to talk to you more about it. If you've got any feedback or questions or concerns, or have someone that you think might be an appropriate referral, please don't hesitate to give us a call.
Thank you, Lori. Well, maybe some folks are typing in some questions. I did have one for you. I imagine that you talked about safety, and then also women's kind of their choices that they make, kind of respecting their choices. So I imagine there's a lot of dilemmas. Could you maybe talk about that, how you kind of deal with those, or in your own practice?
Sure. Well, I think it's important to obviously empathize with their situation, validate that what they're going through is a legitimate concern, something that they should be paying attention to. Part of it is education. A lot of the women that we see, and this is, I think, why we developed this support group, is that we were surprised at how many women who came to us disclosing that they were in these kinds of relationships, and they didn't see them as abusive. So part of it has just been educating them on what a healthy relationship looks like. And then, like I said, validating that what they're going through is something that they have the power to change. Helping them see that leaving is a difficult process. It's not something that can be done easily or even safely a lot of the time. So it's important that they understand that somebody out there is understanding why they are hesitant to leave and helping them and giving them that confidence that when they are ready to leave, there's going to be support available. And that sense of empowerment, like I said before, really goes a long way to make that woman feel more secure in the decision to leave. Leaving is absolutely a process. It's not something that can, well, it's been very rare in my experience that the woman or a woman and her children can leave safely the first time. Sometimes it takes several attempts before they're successful at getting out of that kind of relationship, and sometimes it's not practical for them to leave. They're financially dependent on their spouse. If there's so much threat and intimidation that if they leave, sometimes the abuser may threaten to go to their employer, so they're worried about loss of their job. They make other threats, such as, threats to harm the children, threats to take the children from them, threats to harm other family members or themselves. All of those things really work against a woman feeling like she is capable of leaving. So as you work with these women, it's important to give her the resources that would help her know there are options, and then support the decision whether it's to stay or go. If there's an immediate safety threat, then of course the intervention needs to be maybe a little different, but we have to respect that she's an adult and she's going to make the choice, hopefully before she's hurt or her children are hurt, and just be there for her when she is able to leave that relationship.
Thank you. So if folks have other questions, we will stay on for a couple of minutes. You can, again, just use that chat feature and type them in, and we'll try to answer them. We got a few minutes here. As always, I will email out the presentation so everybody has that and has Lori's contact information. So please, if you have any questions, type those in now. Okay, well, we're not seeing questions in. We will hang around for another 20, 30 seconds to answer any of the questions that may happen to come in between now and then. So to everyone, hope you have a great weekend, and if you're going to be joining us at our TFCBT training in June, we look forward to seeing you there. So everyone have a great day, and we will stay on for another 20 or 30 seconds.